So we will start as people are getting their lunch, so you have enough time to cover the material, both for echo and for MRI. So what you will see in the first few slides are very basic measurements that you need to know. It's a bit dry, but it's essential to know. So when you see units, when you see numbers, you know what the numbers mean. So the first one is the definition of pressure, and pressure is simply force per unit area. If you think of a solid object, the weight of that object applied to a flat surface determines the pressure. The smaller the area, the higher the weight of the object, the greater the pressure. The SI units for pressure is 1 Newton per meter squared, and that is also referred to as 1 Pascal. Frequently, rather than infrequently, what you will see used in some of the measurements, and actually most of the measurements will not be the pascals, but will be millimeters mercury. So we will see the relation between both. How do we derive pressure? So we just said it's force per area. So you replace force as the product of mass and acceleration from Newton's second law. You know that mass is the product of density and volume. And now you look at this expression, density times, say, meter cubed times acceleration divided by meter squared. You reduce this and you end up with the three terms that you see up here, density, acceleration, and distance. When we look about pressure and an object, say, that is at rest, it is exerting pressure that is dependent, or if we talk about a fluid, it is dependent on the density of the fluid. The more dense the fluid, the greater the pressure it exerts. The free fall acceleration, this is a constant that depends on where this object is. Is it on Earth or in another planet? So for Earth, it's a fixed number, 9.8 meters per second squared, and the height above the center of gravity. Frequently, we deal with smaller heights, so not in meters, but in centimeters. And so you can ask the question, if I have 1 centimeter of water, how much pressure does it exert? So you multiply 1 by 9.8 by 1. The first one is an approximation for 1.06 gram per centimeter cubed. Because we are converting meter to centimeter, we multiply 9.8 by 100, so you end up with 980 dynes per centimeter squared. You do the same exercise for millimeters of mercury, and because the density of mercury is 1.36 gram per centimeter cubed, then the millimeter mercury exerts pressure of 1,333 dynes per centimeter squared. Frequently, the question is asked how much 1 centimeter of water corresponds to millimeters of mercury. When you look at someone's jugular venous pressure, you are reporting centimeters of water. You're not reporting millimeters of mercury. So you apply this dimensional analysis, simple thing you took in high school, and you say 980 dynes centimeter is exerted by 1 centimeter of water. So if 1 millimeter mercury exerts 1333 dynes per centimeter squared, then 980 dynes corresponds to how much millimeters of mercury? And you can tell it will be less, so this is the rough approximation, 0.74. So the take-home message from that slide is pressure is dependent on the density, free fall acceleration, and height. The variable that we look at is the height. These are constants for a given liquid on the face of the Earth. And 1 centimeter of water exerts 0.74 millimeters of mercury. The next thing we talk about is quantification of flow. You can think of that as the volume of a cylinder. So the volume of the cylinder is given by area of the base times height. If you assume that the cylinder is a circle, so it's pi r squared, and you can replace r squared by d over 2, and you square it, so you end up with 0.785. Diameter squared times velocity. For those who are interested in tracking units, this is centimeter squared and this is centimeter, so it becomes centimeter cubed per second, which is the unit of flow. For an ellipse, the minor dimension and the major dimension are different, so you need to account for that. And some places in the heart are better represented as an ellipse rather than a circle. For example, the mitral annulus. Notwithstanding the approximation of using a circle equation as opposed to an ellipse equation can still work. If we are looking at a fluid, not blood now, but a simple fluid, as the fluid goes through this tube with a fixed diameter, the fluid, all layers will go in with the same velocity. Then some layers of fluid will start getting attached to the edges of the tube, and they do not move. And gradually the velocity increases as you go from the edge to the center, such that the highest velocity is present in the center, the lowest velocity of 0 is at the edge. We refer to this as a velocity gradient. It's a change in velocity over the cross-section, so it's a spatial gradient, not a time gradient. The distance it takes from where the fluid enters the tube to where you end up with a parabolic profile, as you see here, is referred to as the entrance length. That is dependent on the geometry of the tube and also on the energy that this fluid gets in or the velocity that it gets in. When you think of a solid object moving, you think of friction opposing the motion of that solid object, like when you apply the brakes. For fluids, when we think of resistance, we think of viscosity. So a fluid that has a higher viscosity will be harder to get it into motion, and also will be harder to stop it if it's already moving. Blood behaves as what we call a Newtonian fluid, and what that simply means is that as you increase the tension or the shear that you apply between the layers of the fluid, you will see faster changes in the velocity gradient. What is the relation between viscosity, stress per unit area, and velocity gradient? If we ignore the viscosity for now and just look at that simple expression, this is the velocity gradient, and as mentioned, it's a spatial gradient. That's why it's the differential of velocity in relation to the cross-section diameter or radius of the tube. And S is the tension. Tension is force over an area, so same units as pressure. Since they are proportional, you can remove the proportional sign and put a constant. The constant that you put is viscosity, or mu. We are interested in viscosity, so we can rearrange that expression, and you see that it is proportional, or the viscosity is given by tension multiplied by a unit of distance over a unit of velocity. So you rearrange that and you take out the dimension term, you end up with Pascal times second. So this is the unit of viscosity. Now let us look at the factors that affect the flow of fluid in a tube. The assumptions are this is a constant viscosity, something that doesn't change. The area does not change. It's fixed area from point 1 to point 2. So for fluid to move from point 1 to point 2, there has to be a pressure gradient. First, the pressure gradient is established, and then flow happens. So there is a temporal lag between when the pressure gradient is recorded and when the flow takes place. It's a short time, of course. Let's look at a cross-section of this circle. So we will say that it has a radius of A, and we can look at smaller and smaller concentric circles, circles with the same center, but smaller radii as you go from the outside to the inside, or larger radii as you go from the center to the outside. The maximum velocity is happening in the center. The least velocity of 0 is at the edge, as we just mentioned, and in between, the velocity keeps decreasing. The two forces that determine whether flow will happen and in which direction are the pressure force, so the difference in pressure between points 1 and 2, want to send the fluid from point 1 to point 2. The friction force wants to stop that movement. This is a derivation of that Poiseuille's law, and it's a simple...
This is a very simple equation, Sherif.
It is a simple equation. It's what you can say is, if you are in a high school, something that would fit maybe a junior, at most a senior level, who are taking, say, AB calculus. So let us look. It's really simple if you look at it and sort of dissect what it means. This is the pressure force. This is the friction force. Pressure times area is force. That's what we mentioned first. And we are saying it's a circle. So it's pi r squared. Why is there a negative sign here? Because forces that act in opposite directions get negative signs when you represent them, to recognize that they act differently. This is the tension, and this is the surface area of a cylinder, which is circumference of the cylinder multiplied by the length. Then we rearrange that expression, and that's what you end up with. And we also replace that by the Newtonian expression of viscosity multiplied by the spatial gradient of velocity. Then you apply integration for the velocity from velocity u in the center, that's the maximum velocity, to a velocity of 0 at the edge, and from a radius of r, this is the smallest radius in the center, to a radius of a. So in the center, r is 0, and for the velocity of the edge is 0. So you end up with that term when you do the integration. I will sort of really straightforward, nothing fancy about it. But the bottom line is the maximum velocity is directly related to the pressure difference, directly related to the square of the radius, and inversely related to the length and to the viscosity. If you think about it, for velocity to be high, you want a big pressure difference to let it go through, because you incur resistance. The smaller the vessel is, then you want a bigger vessel to have less resistance and higher velocity. Viscosity is a factor that slows velocity, so you want viscosity to be in the denominator. We are interested in flow and not necessarily just the maximum velocity. Flow is given by area multiplied by mean velocity, and the mean velocity is roughly half the maximum velocity. So that's why the famous expression of Pascal, of Poiseuille's law, says that the flow is directly related to the fourth power of the radius and inversely related to viscosity and the length of the vessel. You can think of this as a resistance term. If you are familiar with voltage, electricity, and resistance, P1 minus P2 corresponds to the voltage, Q is the current, and R is the resistance that we look at. Of course, resistance is is the opposite of flow in terms of how it relates to these variables. So when you are reading something or looking at a question, read carefully. Are they talking resistance? Are they talking velocity or flow? So can Poiseuille's law be applied to the flow in the circulation? Yes. It can be applied more of sort of the general terms as opposed to quantifying precisely actual flows. And these are reasons why Poiseuille's law may not be sort of valid if you were to have all these variables and just substitute them. You may end up with flows that are different from what the equation predicts. So the first assumption is constant viscosity. If you look at smaller and smaller vessels, red blood cells will not get into these smaller vessels. Red blood cells determine the viscosity of blood. So the viscosity is no longer a constant factor in this calculation, but is variable. We talk about laminar flow as opposed to turbulent flow. If you're looking at a normal circulation, it's a very short distance where there may be turbulence, just as the blood leaves the aortic valve or the pulmonic valve. And if you ignore that very short distance in a normal heart laminar flow, which is assumed in the Poiseuille's calculation does hold. Circular tubes for the most part, but you can imagine that the arteries and the veins are not necessarily circular in cross-section. Further, their diameters can change during the cardiac cycle. This takes us to the assumption of this being an inelastic tube. Remember, when we were doing the calculations, we did not entertain the possibility that the diameter can change. Obviously, in arteries, it will change during systole with expansion. And finally, steady flow. Flow in the circulation is pulsatile flow with a varying velocity profile. One way of dealing with this is saying I am going to measure the flow at several time points during systole, and then I will go for a temporal average. Okay. Another number you are expected to know is called Reynolds number. And simply this number tells you the likelihood of whether turbulent flow will happen or not. If the Reynolds number is exceeded, turbulent flow will happen. If it is not exceeded, then it will not happen. And the Reynolds number does vary based on the density of the fluid that you're looking at, based on the velocity with which the fluid is moving, and the diameter, and of course the viscosity. For those who are interested, Reynolds number is a dimensionless parameter, meaning it has no units. Because if you work your way through the numerator and the denominator, they will cancel out. So now we talked about flow, and this is a slide you saw before. The take-home message are these two equations for a circle and for an ellipse. You need to know the diameter. You need to know the velocity, or the two diameters, the major and the minor diameter for the ellipse. So we frequently calculate areas when we quantify flow. For example, flow through the LV outflow tract. Are the area calculations accurate? So for the most part, they can be accurate, or they should be accurate. Reasons why you may make mistakes in your area calculation include diameter measurement. This is straightforward. If the diameter is 2.1 and I measure it 1.8, I measured it wrongly, my area calculation will be wrong. The second one, and already alluded to, is the geometric assumption. You assume it's a circle, whereas it's an ellipse. Example, the cross-section of the mitral annulus. The third one, the issue of phasic flow and instantaneous area. Many times when we, not many times, always when we quantify, say, flow through the LV outflow tract, I do one diameter measurement, and I make the assumption that throughout the duration of ejection, throughout systole, that diameter is fixed. It does not change. The truth is, it does change. You probably see more variations on the right side in these areas than on the left side, but overall, these are minor changes. How about absolute flow and changes in area? This is an important fact that we make use of. So if you get an orifice and you let a small amount of blood flow through that orifice, and you measure the orifice area, and then you force a larger amount of blood or fluid to go through that orifice, and you measure the orifice area, you end up with a larger orifice area. This was shown in vitro, has been shown in humans as well, and the clear application is when we look at patients with aortic stenosis, depressed EF, small stroke volumes, and we calculate a small aortic valve area. If you give them dobutamine, and assuming the ventricle is able to respond to the inotropic drug, it forces more flow and you end up with a larger area. How about the appropriate site for measurement of diameter? Remember, flow is coupling area and velocity measurements together. They have to be measured at the same spot. For example, I cannot use measurements, say, in the descending aorta by pulse wave Doppler velocity and use the cross-sectional area of the LV outflow tract. They should be at the same level. Finally, earlier on, not necessarily now, though is becoming of more interest with the use of 3D, investigators have looked at, instead of us having to do diameters and make geometric assumptions and carry over errors between diameters and area, let's just measure the area. To the extent that you are able to measure the area accurately, things are okay. But if you make mistakes in the area measurement, then you will make mistakes in area and calculation of flow. A famous question asked is, if I make a diameter error, what is the percent error in the area? Most people invariably answer it's squared, because the area is given by the diameter squared, 0.785. This is not correct. And that's sort of the reason. If you are asked does anybody know what's a mean percent error? If you have a set of statistical data and somebody asks you what's the percent error here. So you look at what is the correct measurement. You see what your measurement is. You get the absolute difference between them, not the algebraic difference, and you divide it by the correct measurement. Express it as a percent. So in that situation, this is the error in the area, and it's defined as the difference between the two areas divided by area 1. And then we say the relation between the diameter and the area. We say that in the second situation, I am overestimating the diameter by delta L. And you sort of break down that expression that you see on the third line. This is a simple algebraic thing, like a 8th grade or 7th grade if you start early algebra. They go through that, you cancel these, and then first grade they don't take algebra. But 7th grade, that's material you would see. So it's delta A over A1, and you cancel the L1, so it's simply twice the error in the diameter measurement. So if it's a 10% diameter, it's a 20% area error, and so on. Now, we are quantifying flow. So I made a mistake in the diameter measurement, and I will submit to you most people who go through these calculations, and you can check yourself. When you make errors, most frequently it's in the diameter measurement, not in the velocity measurement, if you know how to measure the velocity correctly. Much more reproducible to measure velocities than dimensions by echocardiography. Probably true for MRI, too? Okay. More reproducible to get velocity measurements as opposed to dimensions or areas measurements? Doesn't matter for you. Okay. Well, for us, it's the diameter that is the Achilles heel for mistakes here. So there is the assumption of uniform spatial velocity. Remember, echocardiography is as tomographic planes. You are measuring velocity in one plane. The velocity that really matters is the 3D representation. But that's not what we are measuring. So if there are differences along the x, y, and z axes of the velocity, the one that you want to use is the net one or the overall vector as opposed to one in one particular plane. It's important to remember this, not just for flow calculations, but also for other approaches that are sort of gaining some interest nowadays as intraventricular flow vortices. All of the available ultrasound systems just measure it in an XY plane, but they do not get the projection of the velocity along the Z plane as well. We covered the first 2 points. We talked about the 3D. The signal strength is an important thing. Sometimes we get a weak signal strength. If the signal strength is weak, the true velocity may be, say, 80 centimeters per second, and what I am measuring, because this is what I see, is 50 centimeters per second. You frequently see this in patients who are on a mechanical ventilator. In this situation, if you wait and acquire more cycles, you can present them for whoever is reading, and they will be able to select the proper signal strength. Non-simultaneous measurement of area and velocity, not a problem for people in sinus rhythm, but when there is a lot of arrhythmia, when there is atrial fibrillation, that becomes a problem, and you have to choose RR intervals that match. Finally, the assumption of continuity, which means that the flow at one point equals the flow at a second point. Highlighting that in a normal situation is, for example, flow at the LV outflow tract, I would say is equal to the flow at the level of the descending aorta. The answer is not true, right? Because between the LV outflow tract and the descending aorta, some blood already left for the coronary circulation, some blood left for the cerebral circulation. Cardiac output is cross-sectional area times velocity time integral. Nowadays, you do this on the ultrasound system. You can do it offline also on your system that you use for quantification. You can use geometric assumptions. We don't need them nowadays. And then the product of stroke volume and heart rate. If I can calculate cardiac output, then I can look at what is happening with medications. We and others have looked at the use of drugs like dobutamine, milrinone in patients with heart failure, used echocardiography to measure stroke volumes and cardiac output to document a hemodynamic improvement with the drug to justify giving this as an outpatient treatment for some patients who have advanced heart failure. You can look at the effect of different pacing modes, AV sequential pacing, biventricular pacing, LV pacing, pacing at different sites of the LV, and see which one results in the largest increment in stroke volume and cardiac output. You can look at physiologic changes for women during pregnancy, after delivery. You can look at what happens to fetuses and neonates. There was an interest sometimes of children who are born with hyperbilirubinemia, then they give them phototherapy to deal with bilirubin and how that affects cardiac output. Exercise Doppler is gaining interest nowadays, though it is more challenging to get satisfactory signals during exercise. These are all applications from the continuity principle, and let's go through sort of simple examples through them. So in a normal echocardiogram, we use flow through the LV outflow tract to quantify cardiac output. How do we measure the LV outflow tract? We go in a parasternal long axis view. We want to zoom on the LV outflow tract. The zoom function is important because you end up making less errors when you do that than when you use the scale that is much larger than this. And you measure it as illustrated. You go to the LV outflow tract and you record the flow. Notice just one click, not two clicks. If you see two clicks, you are in the valve. That is not a correct position. Notice also that we are tracing the brightest signals. The brightest signals are the signals that are coming from the most red blood cells having the same velocity. We call this modal velocity. If you do not use the modal velocity, say you have something faint outside, like in that area, and you go after it, you will end up with a larger TVI than what the actual time velocity integral is. Do you see that signal? Should we include it or should we not include it? Who would favor including it? Nobody? Okay, why? Any volunteer? You would not include that one because it's happening in late diastole, before the QRS complex. That's an blood flow that has sort of propagated within the ventricle and is making its way to the LV outflow tract. An indirect evidence of a vortical or a flow due to a vortex that you haven't, but we haven't shown you the actual vortex, but this is what that is. You also can record flow through the RV outflow tract. This is a long axis view of the PA from a short axis from a parasternal position. You can also get the standard parasternal short axis view. You get the RVOT time velocity integral. For the mitral valve, we record flow at the level of the annulus and at the level of the tips. You need both of them. The annulus for quantifying flow, the tips for looking at diastolic function parameters. This is how we can use these concepts to quantify mitral regurg volume. There will be other talks on these, but this is just to show you how this continuity equation applies. When the ventricle contracts, some blood goes out through the aortic valve and some blood goes back to the left atrium through the mitral valve. So the total stroke volume, what we refer to as 2D stroke volume, difference between end diastolic and systolic volumes, is made up of both of these. If I know the stroke volume and I subtract from it the aortic flow, then I have the MR. Example of a patient with a flail segment and a lot of MR shown here by color. We get the mitral annulus diameter. We get the mitral flow by at the level of the annulus, pulse wave Doppler, LVOT flow, LVOT TVI. Then we plug in the numbers. These are the numbers. You apply the calculations. So the top line shows you the flow through the mitral valve in diastole. This is the total stroke volume. The second line is flow through the LV outflow tract. The difference between them is the regurgitant volume, and if you express that in relation to the total stroke volume, you get a regurgitant fraction. We can do the same thing for aortic regurg. We get flow through the LV outflow tract. We get flow through the RV outflow tract. The difference between them is the AR volume. Energy, pressure, and flow. Energy is defined as the capacity to do work. It has the same units as work. Work is given by force times distance. This is for a solid object. In terms of fluids, we can replace force by pressure times area and distance. Area multiplied by distance is volume. So if you know the pressure of a fluid and you know the volume of the fluid, now you know the work that has been exerted. So we can quantify something called the stroke work during the cardiac cycle. You can do this by echo. You can also do this invasively. Rather than sort of show you the derivations, there are two famous terms that we work with frequently, the terms kinetic energy and potential energy. As the word implies, potential, it's something that it has by virtue of where it is, which is basically the height above the center of gravity. Kinetic is the energy it holds because of its motion. And in the first expression is the velocity squared that enters into the calculation. Bernoulli's law and some applications here with the continuity equation quickly. Think of this as the LV outflow tract at point 1, and think of point 2 as, say, the aortic valve in a patient with aortic stenosis. Because of the continuity equation, flow at point 1 equals flow at point 2. So area 1, velocity 1 equals area 2, velocity 2. If you are interested in area 2, then you rearrange this expression and you are able to calculate velocity 2. Since the area is smaller at point 2 and flow has to be equal between points 1 and 2, then velocity at point 2 is higher than velocity at point 1. The smaller the area, the larger the velocity. That's why in a normally contracting ventricle, the higher you see the velocity of aortic stenosis, assuming no other variables influencing the flow, the worse the severity of the stenosis. Also, because velocity is higher at point 2 than at point 1, and kinetic energy is directly related to the square of the velocity, kinetic energy at point 2 is greater than kinetic energy at point 1. This is the full expression of the Bernoulli equation, and it's a simple equation if you limit yourself to what terms it shows. So the energy is in part pressure energy. The second term is kinetic energy. The third term is potential energy. If we limit our analysis to points 1 and 2, both of them are the same height above the center of gravity. So you can cancel out the potential energy terms. Okay? So now we say pressure 1 plus kinetic energy point 1 equal pressure 2 plus kinetic energy point 2. So the pressure difference is given by half density V2 squared minus V1 squared. If you have an V2 that is much higher than V1, then the square of V2 is also much higher than the square of V1, which means we can ignore V1. The only situation where it becomes valid to ignore V1 is if you're looking at a big difference between them. For example, a V2 of 3 meters per second and a V1 of 0.8 meters per second. You can ignore V1 here. And that's the expression. Then we all are familiar with the modified Bernoulli. Those who have been in the lab have heard this before. Sonographers know this quickly, that it is 4V squared. And this is the dimensional analysis showing you how we arrived at 4V squared. Quickly, pressure is 0.5 times density times velocity. And if you convert the velocity from meters to centimeters, you end up by 10 power 4, and you apply this, you will get the 4v squared. One important limitation of the Bernoulli equation, or two important limitations, is ignoring an inertial term and a resistance term. These should not be ignored sometimes. Applications for pressure gradient calculation are shown here. PA pressures, so TR peak velocity plus RAP gives you PA systolic. This is for the PA diastolic pressure and mean pressure. The diastolic pressure is the end diastolic velocity plus an estimate of mean RAP or RV EDP. We depend on CW of the aortic stenosis jet to get the 4V squared and the peak velocity and gradient through the aortic valve. Remember, what we measure by echo are instantaneous gradients, and these are measurements indeed through the narrowest point of the jet. By cath, they do not get into that narrowest point, and they frequently get a bit ahead of that. That is at a point where there is some recovery of pressure as well. So almost always gradients by echo, peak gradients, are higher than what you get by cath. Mitral stenosis, to look at gradients, and this is a nice slide in a patient with atrial fib showing you how reliable the gradients we get by echo compared to the gradients we get by cath. You can go one by one, beat to beat, and they are almost identical. You can depend on it to get dynamic obstruction gradients, as in patients with, say, hypertrophic cardiomyopathy, and that's an example, 4V squared with a peak velocity of 6. You can use it to quantify dP over dt. This is not frequently done in most labs, but more in research settings. You basically choose 2 points, one for a meter, velocity 1 meter per second and 1 3 meters per second. And you convert them by the modified Bernoulli equation to their corresponding millimeters mercury. So you got the delta P, and all you have to do is divide 32 by the distance between these 2 points, the time interval. You can use it also for the right ventricle, and even if you do not want to measure, you can look at the slope. Look at how fast the velocity is changing here in a normal RV, whereas in a depressed RV it's changing very slowly. You can also apply it to look at LV end diastolic pressure if you know the aortic regurg end diastolic velocity and you know the diastolic blood pressure. There are limitations to some of these assumptions, but the whole idea is to sort of highlight how we use the pressure gradients calculations to come up with a number of useful parameters. And I'm done here.
Okay, thank you, Sherif. And, okay.
So I'm going to turn a little bit now to CMR and how it can be useful for hemodynamic assessment. So first thing I want to do is talk a little bit about what is the technique that we utilize. And basically it's a technique called phase contrast CMR. And let me just kind of walk you through some of the basics behind it. And it really works by this principle shown here, which is if you look at stationary tissue, notice when I apply a gradient, I guess it's not working. Okay. If you apply a gradient, what will happen is you'll cause basically a net shift in magnetization of the protons. When you reverse that gradient, when you apply an exactly opposite gradient, stationary tissue, the net shift goes back to its steady state. But what happens is if there's blood flow that's moving along here, it sees different gradients along the way. And that's kind of the basic principle behind how CMR is able to actually try to encode for what the velocity of flow is in any given pixel. So let me kind of walk you through some examples here. So whenever you run a phase contrast CMR sequence, you get really two sets of images. One is called a magnitude image, which basically shows you the background anatomy. And then the second is what's called a phase image, which actually encodes for both the direction of flow as well as the velocity of flow. Yeah, this, okay. So you'll notice in this case, here's a phase contrast acquisition that's done in an axial orientation. We can see the ascending aorta here, and we can see the descending aorta here. And so obviously flow in the ascending aorta, you would expect to be going in a different direction, in the opposite direction from flow in the descending aorta. And as a result, flow in the ascending aorta in this case is encoded white, whereas flow in the descending aorta, which is going in the opposite direction, is actually encoded black. Now, the intensity of the color is directly related to the velocity. So, for example, a higher velocity jet or higher velocity flow in the head to foot direction would show up as a brighter white versus a lower velocity flow, which would show up as a less bright white. And you can see this actually, an example of this. If I look at descending aorta flow here, and you look at SVC, which is right next to the aorta, look at the intensity of the black in the descending aorta compared to the intensity of the black in the SVC. Flow in both of those are going in the same direction. They're both going from head to foot. But since the velocity is higher in the descending aorta, you can see it's a more dark black compared to the SVC. So in addition to just simply looking at what the intensity is, the scanner will actually take those values, and basically that corresponds to a particular velocity value. So there's a couple of important things when you're doing the acquisition that it's important to recognize. One, obviously, is you want to pick the imaging plane to identify whatever vessel it is that you're interested in imaging. And then you have to decide whether you want to do what we call in-plane imaging or through-plane imaging. So I'll show you the difference between the two. So if I'm looking for blood flow that's within my plane, that's what's called in-plane imaging, and that's what's shown in the top image here. And you can see flow in the descending aorta, which is going within your plane. That's different than the bottom panel, which is showing you through-plane imaging. So that's blood flow that's coming through your imaging plane. So you have the ability to choose which you want. Now, from the standpoint of quantitating flow,
So parallel to versus perpendicular to?
correct, exactly. Now, when you're quantitating flow, that's going to be done using through-plane acquisitions. So through-plane is what you use to actually quantitate the magnitude of flow, the amount of flow. In-plane allows you to just see the direction of the flow, see the jet, but you don't really use that for quantitative purposes. Now, so if I wanted to do a assessment of flow, let's say in the aorta, what I would do is I would place a imaging slice that's above the aortic valve, as is shown here. Now, you want to try to make sure that you're as perpendicular to the vessel of interest as possible. And so to do that, you ideally want to line it up off of two orthogonal planes. So I've got two orthogonal planes that I'm using to actually line up now a plane that's going to be perpendicular to the aortic root here. And then when I run that phase contrast CMR technique, which it automatically advanced to, I'll get an image there, which then I can draw a region of interest. And what it will actually give me is not just one image, but it will give me a series of images at slightly different points in the cardiac cycle, right? Because this is actually a movie that we're doing, and I'll come back to this in a second. But let me show you, is the angle that you utilize, is there importance to the angle? So obviously, what happens if you're off axis? So the more off axis you become, the more of a potential error you could have. But the one advantage is, you'll notice, obviously, is if my flow is going in this direction, if I'm perfectly perpendicular, that's going to be the best acquisition. If I'm off at a slight angle, a 5-degree angle, what will happen is I'll have a slight underestimation of velocity within each of those given pixels, but I'll get a slight overestimation of the area. So to some extent, those two factors actually correct for themselves. So in this study, they actually demonstrated, in fact, that you can have variances from anywhere from 10 to 20% in angle without having a significant variance in both the peak velocity or in the flow assessment. And so these authors concluded basically that about a 10 to 15% or 10 to 15 degree deviation from being perpendicular will still produce an acceptable error. Will still give you measurements that are within 10% of each other. Now, obviously, you want to try to do it so that you're as perpendicular as possible. So you want to try to be meticulous in doing that. But to some extent, there is some forgiveness if you're off angle by a little bit. The other advantage also with CMR is that you're not really limited by acoustic windows per se. So you can simply move a mouse and make sure that you are perpendicular to the vessel that you're interested in imaging. You're not limited by structures that physically may prevent you from being perpendicular to the vessel of flow. Okay.
About calibration that you have to do before
Yeah.
before every test regarding flows. Where does that?
Yeah.
I don't know
So.
if you're going to talk about it.
Yeah, so basically, yeah, I'll have some stuff at the very end, which is just that there can be some offset errors that can occur. Those are oftentimes due to the scanner itself. And so there's two ways you can try to calibrate that. One of the methodologies you can use is actually to place a phantom, stationary phantom, in there and try to say, okay, at this exact same location where I'm imaging my aorta, I'm going to put a phantom in after I take the patient off and say, what velocity is the scanner measuring at this location? It should be 0 because you know it's stationary. So if it's measuring some velocity, then you know there's a little bit of an offset error, and you try to adjust for that. Now with newer sequences, we have a kind of an intrinsic way that we can do that, which is without having to take the patient off and put a phantom on, which is, so if I'm measuring the ascending aorta here, well, I've got some stationary tissue that I could easily measure, which is the chest wall. And so oftentimes what we'll do is just draw a region of interest in the chest wall and say, what velocity are we picking up in the chest wall? Again, you know it should be 0. If you're picking up some velocity in the chest wall, you can actually tell the software to correct for the background velocity that you're picking up in some stationary object that's nearby. And so whenever we look at the data, we will actually get two sets of curves. One is without correction, and the second is just with an offset correction that's done based on whatever it measures for the background. So that's one of the ways that you can do offset correction. But the magnitude of the offset errors now, I think, is not as much as it used to be in the past. And one of the reasons for that is those errors can occur if the vessel you're imaging is further from the center of the scanner, right? So we have now with pretty much most scanners that are available now, if I'm picking an imaging plane at this location, what it will do is it will automatically move the patient, moves the table so that my imaging plane is at the center of the scanner. So that reduces some of the error. Now obviously that can't reduce the error of, let's say, left to right. You may not be in the center of the scanner from left to right direction or anterior to posterior, but trying to do this background correction is one of the ways that you do that. Okay, so let's keep going here. So the other thing that's important is you have to, when you're doing the acquisition, it's important to set the optimal velocity encoding, which means basically you're telling the scanner, this is the range of values that I want to interrogate. All right? So you have to have some idea of what the expected flow would be in that area. And I think this is analogous to echo. If you're interrogating for an ASD, for example, you're going to want to be looking at a lower range of velocities than if you're interrogating for aortic stenosis. And the same principle happens here. If, for example, I've set my velocity encoding too low, what you'll get then is you'll get this aliasing phenomenon. So now notice the aliasing will happen. Here's an example of what the flow curve would look like. Now notice what happens is the aliasing happens primarily during peak systole, right? That's when you get to the highest velocities. And if the range of velocity that you've encoded, in this case, for example, let's say the peak velocity is about 330, but I'm encoding for velocities between 0 and 300 meters per second, centimeters per second, then anything that's above that 300 actually wraps around. So I can see that visually on the image as this aliasing artifact, and if I were to draw an ROI and actually compute the velocities, I would actually see that the scanner would get fooled into thinking that this velocity here is not over 300, but in fact it's much lower than 300. So when you see a curve that looks unusual like this, that's your clue that there's aliasing. But quite honestly, even before you get to the point of even doing the tracing, you can simply tell that just by looking at this image here and seeing that, hey, it doesn't make any sense. Why would I have all this white and then have this black pixel right in the center? And then obviously, if you're too far off from the velocity, then in fact you can see a larger amount of this aliasing. And you'll notice that the aliasing happens for longer duration of systole. So in this case, you'll notice this is a perfect acquisition. See the way the curve looks. In this case, really for that little bit in peak systole, for a couple of frames, you're getting aliasing. And in this case, where I've set the velocity encoding way too low, it's set for 200, when in fact the velocity here is 330, you can see there's a significant amount of aliasing that occurs, and it starts to occur very early on during systole, in the early part of systole. So obviously for the text, this is something that you would not want to trace. So if you have an acquisition like this, you redo the acquisition, and when it comes time to doing the post-processing, obviously you don't want to do the tracing on this one. You want to do the tracing when it's redone properly with the correct vanc on this one. And that's why it's important to have some idea what the range of velocities you're going to be expecting at whatever structure you're imaging, because otherwise you're just wasting a lot of breath holds, right? Because you don't want to do extra stuff if you don't need to. Now the flip side you may say is, okay, why not always just use a very high velocity encoding? And it's the same principle as an echo, which is if you use too high of a value, then you don't maximize your dynamic range. You get a poor dynamic range, and you don't maximize the grayscale. So as a result, this, for example, is an acquisition that's done with an optimal vanc where I see a nice bright for the ascending aorta and a nice black for the descending aorta. In this case, both of the ascending aorta and the descending aorta, they're still white and black, so directionally they're correct, but you'll notice the images look fairly washed out. And if you actually go through and try to quantitate it, what happens is you get a lot more background noise, because if you're interrogating velocities that are in the range of 1 to 2 meters per second, but you've set a velocity encoding for 5 meters per second, you get a lot more background noise. That noise can randomly cause an increase or decrease in your peak velocity assessment, and that leads then to more and more errors as your vanc is higher and higher from what the optimal is. And so the goal really is that you want to use the lowest vanc that you can get without getting aliasing. That's ideal. But I mean, the reality is you don't need to chase it down to that extreme, but I would say is you want to try to be within about 50 centimeters of what the true velocity is. Okay, now, so where is it that we use this information? And how is it that we use it? And so Sherif already talked nicely about the fact, the velocity encoding CMR gives you information about velocity within any given pixel. You can then take that, multiply by area, and derive flow. And then if you take flow and multiply that by time, you actually get a flow volume. All right, so all of this is done essentially by post-processing. And so here's an example of what a phase contrast CMR acquisition would look like. You notice it's actually a movie that I'm playing here. So it's multiple phases that are all taken at slightly different points in the cardiac cycle. So these are typically about 40 to 50 milliseconds per phase. You would then simply go through and draw an ROI here in the ascending aorta, or if I wanted to measure flow in the descending aorta, I could draw an ROI in the descending aorta, draw that for each phase. Now most of the software packages now, once you draw one phase, they can just automatically propagate that through all the phases. So the post-processing time here is actually fairly minimal. It's probably 30 seconds to a minute, so it's not cumbersome at all. And then once you've done that for each phase, the scanner will then essentially summate the velocity times area, and it then gives you a flow curve. So it does it for each phase in the cardiac cycle, and you're able to generate a flow curve. We can also see a curve which shows us just what the velocity is over time, either the mean velocity, which is the average velocity of all the pixels that you've drawn, or the peak velocity, which would be the highest velocity of any given pixel within this area here. So there's different ways of doing it. And then obviously for flow, where it would summate the area times the velocity information, and it would then derive for you a forward flow. You could also see if there was any reverse flow. You'd actually see retrograde flow that's occurring throughout diastole, for example, in the aorta. Now, how good are these measurements?
Anything for, let's say, if you're at the sinotubular junction.
Right, coronary flow.
See that coronary flow?
Yeah. So sometimes you'll see a slight little negative blip at the very, very onset of diastole. A few cc's, and that's your coronary reverse flow. Yep. So how good are these values? And so how would you go about validating these? Well, one obviously is there were numerous validation studies that were done using flow loops, where you know what the magnitude of flow is. But what about as far as validation in patients? So there's two ways that the validation studies have been done. One was they took patients and they said, okay, let's measure what is the flow by CMR that we would derive in the ascending aorta, and what is the flow that you measure in the SVC and IVC. So obviously these flows should be equivalent to each other. So aortic flow should be equivalent to the SVC, IVC flow. And in this particular study, that's what they did, and they demonstrated, in fact, across a range of flow values, a pretty nice relationship between aortic flow and the sum of your SVC, IVC flow, or your venous flow. So
studies are like this one. This is the mother of perfect. The slope of one and an intersecting
Yes. Yes. So here's another study. This is showing correlation to cath. And these are, both of these studies are fairly old. These are all 15, 20-year-old studies. This was a publication in Circulation in 1995. And again, this is looking at the stroke volume average between thermodilution and FIC. Compare that to the stroke volume derived by CMR. And it looks like a reasonably good correlation. Again, maybe not perfect. R value of 0.9 or so. And then this, in fact, from that same study, they in fact actually showed that this is a Bland-Altman analysis here, comparing CMR versus the mean cath values based on both hemodilution and FIC, or thermodilution and FIC. And this actually is what the variation is just between FIC and thermodilution itself. So between two cath techniques versus between CMR compared to the sum of the two cath techniques. So showing again that the variation that you get is similar to the variation that you would get just by cath itself. Pardon me? Well, I don't know that you can. I don't know that you can assume it's better. I think you can say that it's comparable to the variability that you get by cath in and of itself. So where you can also utilize this then obviously is now in patients who do have shunts, intracardiac shunts, where you can actually use this to measure what is the flow going through the PA and what's the flow going through the aorta, and from that try to derive what the QPQS is. And here's an example of one particular case where you can actually measure that the flow in this example patient who has an ASD through the pulmonic valve was 131 cc's, or through the pulmonary artery, compared to flow in the aorta, which was 82 cc's, suggesting in fact that there is a shunt and there's a QPQS ratio of 1.6 to 1. Now, this is one particular study comparing QPQS by oximetry to QPQS-derived measurements by CMR, published in Circulation in 2001. Again, showing a reasonably good correlation between CMR-derived QPQS measurements and that derived by oximetry. And then here's another study from 2008 looking at a series of patients with atrial septal defects. And in this study as well, if you look at oximetry compared to a indirect method, so this is comparing QPQS by oximetry compared to QPQS by CMR, you can show a reasonably good correlation, but in fact a better correlation was obtained in this study if you did a direct measurement at the atrial septal defect itself. And the method they used here, because again with CMR you can measure it in any plane you want. So instead of measuring in the aortic and pulmonic planes, you could actually then find a plane that takes you through the atrial septal defect, and that's what's done here. So now I have what's called an NFOS view of the ASD itself, and you can actually measure what is the through plane flow going through this atrial septal defect. And
But unfortunately, there's a lot of contamination.
Where? Here?
I mean, there would be, because, see, most of the other orifices that you look at, there's a two black structure.
Yes.
And here, it's basically a membrane with flow. So it would be very hard. I mean, you can have some entrainment that flows
Right.
around it.
Right.
So the cross-sectional area
Yeah.
of flow
Yeah.
is not as accurate.
Right.
It's good, but I'll give
Right.
you a ballpark.
The one advantage of this, because is here you're doing one measurement, as opposed to when you do QPQS, you're making two measurements. Anytime you do two measurements and try to do a difference between the two, you can compound the errors. And so that's why in this particular case, they actually demonstrated a better correlation with the direct methodology than with the indirect method of just comparing aortic and pulmonic flow. But again, I think both of these showed reasonably good correlation. The key here, though, there's a couple of things with this, obviously, is you have to make sure you try to be meticulous about getting a perpendicular plane through the atrial septal defect. And so usually we do anywhere from 2 to 4 scout images to try to, in the long axis orientation, identify where the flow is going, and then off of those then prescribe a perpendicular imaging plane. So this is actually how we do ASD assessments in the CMR lab typically as well. Now, where this could become problematic is when you have these fenestrated ASDs, or you have ASDs that have a significant amount of movement right, throughout the cardiac cycle, where it may be hard to get truly a perpendicular imaging plane to the atrial septal defect. The one advantage of that methodology, though, is it helps you, if you find a significant difference between your direct assessment of ASD flow versus your QPQS measurement, that is a tip-off that maybe there's another shunt somewhere else. So that's where you can use this to say, well, maybe there's now, it raises suspicion that maybe there's an anomalous pulmonary vein, or maybe there's multiple atrial septal defects, or other things. So we use that to kind of go back and say, we need to take a closer look at this case and see if there's additional information that may be derived. And in fact, in this study, that's what they showed, is that if you just simply do the measurement here and you compare that, you may find there's a significant difference between this direct flow and your QPQS measurement. And in that case, that's a tip-off to look, and they found in this case a second atrial septal defect. In this example case, where they found there's anomalous pulmonary vein leading to additional shunting, or in this example case, where you see that there's actually multiple defects that are present. So I think it's, the advantage with CMR is that we actually will utilize multiple ways to try to quantify the severity of the shunt with an ASD. And then you can also use this, for example, in coarctation cases. I'm going to skip past this in the interest of time and just kind of wrap up here. With maybe the next frontier, which is instead of, everything I've showed you up till now is basically two-dimensional imaging. So it's 2D phase contrast imaging. But now there's these newer techniques where you can actually do 4D flow. So you're actually measuring a full 3D volume multiplied by time. So you actually are getting 4 dimensions. And there may be some advantages with that, because now you're not dependent on having been certain that you got the correct imaging plane at the time of acquisition. You can go offline after the fact on the 3D workstation and simply pick whatever imaging plane you want to interrogate with. Now, obviously, this is not something that I would say is ready for primetime clinical use yet, but I think it's something that certainly offers promise in the future. So I think to kind of summarize, CMR is able to provide a robust assessment of flow as well as assessment of shunts, is independent of acoustic windows, and the advantages are that you can measure flow really in any structure you want, whether it's ASDs, SVC, IVC flow, aorta, any part of the aorta that you're interested in. So I think CMR is definitely has a role for assessment of hemodynamics in certain patients. So let me pause there. Thank you for your attention.